this is not a scheduled talk. This is by Dr. Harsha supposed to have been, and I just came to know he's not here. So I had a talk, so I thought we'll fill it up. So this is not a fully structured talk, so kind of apologize for that. So we can divide it into a blunt injury and a penetrating injury as we've been going through that. And this is a typical person who has blunt injury. So you'll be surprised to know that 90 to 100% of the patients who have sustained eye injury are males. And the mean age is around 29 to 38 years. So it's a young active male who sustains the injuries. We went through this earlier. So before we send the patient across or take the patient up for any eye injury management, we need to make sure the patient doesn't have any life-threatening injuries. So you can divide the blunt injury into an intact lobe and a globe rupture. So let's look at some of those with an intact globe. This is a common finding which we come across. Patient presents 2 days after a blunt injury, a ball being stuck on the eye or something like that, with the whitening of the retina. So this is what we call as commotio retinae. And why this happens is, it's because of fragmentation of photoreceptors and RPE damage. It's not just an edema. It's actually a death of the photoreceptors. It's really a fragmentation of photoreceptors and retinal pigment epithelial damage which gives rise to this appearance of a commotio retinae. And if you look at the OCT, you see a little high reflective area out here. So this is a sign of the commotio retinae which can be picked up by an OCT. And as I mentioned, this is a photoreceptor damage. This is a much more extensive commotio. You can see commotio extending even all across the posterior pole. So what happens to these patients? What do we do with them? We usually follow them up, and subsequently maybe about 4 to 5 weeks later they come back, most of them with almost a normal looking retina. The common question is whether we use steroids, oral steroids, systemic steroids. There is nothing in the literature to support it. And as I mentioned, there is a fragmentation of the photoreceptors. It's not an edema in that sense of the word, so steroids do not help and do not have any visual impact. Most of the patients do come back to normal with normal vision. But some of them will land up like this with a traumatic macular hole or an RPE alteration out here, which can limit the visual recovery they have. Another common finding when the patient sustains a blunt injury is bleeding. So many of them may have a subretinal hemorrhage. Fortunately, in this patient is away from the fovea, and some of them may have a preretinal or subfoveal hemorrhage, particularly those who sustain a choroidal rupture. So whenever we see a subretinal hemorrhage, we need to look for this. A particularly large hemorrhage, when it absorbs, this may become visible, the choroidal rupture. As long as it doesn't pass through the fovea, patient will have good vision. But even in these patients, we need to make sure that the patients are followed up closely for the occurrence of a choroidal neovascular membrane. Because there's a rupture in the RPE, a choroidal neovascularization can grow to this, and subsequently patient can develop distortion and metamorphopsia. So it's better to give them a home amsler, ask them to check their vision and look for metamorphopsia. And after an injury, usually in the next 3 to 4 months is when they develop, so better to call these patients for re-evaluation during this time. This is a young baby about 2 years old. I think it's one of the rare situations of battered baby. The parents had gone to work, and the work help, like domestic help, had probably battered the child, and child had an intracranial hemorrhage, and that can present with a Terson syndrome or a sub-ILM bleeding. So you can see the ILM being removed. The hemorrhage in Terson syndrome is under the internal limiting membrane. I think it's one of the rare situations of battered baby. The parents had gone to work, and the work help, like domestic help, had probably battered the child, and child had an intracranial hemorrhage, and that can present with a Terson syndrome or sub-ILM bleeding. So you can see the ILM being removed. The hemorrhage in Terson syndrome is under the internal limiting membrane. So child had this sub-internal limiting hemorrhage in both the eyes. And because these are growing eyes and with the potential for amblyopia, these people would have to be operated upon earlier to prevent an amblyopia. Another common occurrence after blunt trauma is traumatic macular hole. So in this patient, it is associated with a big scar as well. If there is no scar under trauma, just a traumatic macular hole, we can go ahead with surgery nowadays. Even large holes, we can close them by a little modification of the existing macular hole surgery technique. This is an inverse flap technique where we peel the ILM from all around and leave a little bit of a scaffold in the center, bridging across the hole, and even larger holes as big as 1,500 microns do close after the surgery. There is one such patient who had a traumatic macular hole. As you can see, this is about 1,000 microns in size and closed after the surgery with improvement in vision. Post-penetrating trauma or a blunt trauma, you can have some small problems like an epiretinal membrane. You can see this thick glial tissue scar out here in the posterior pole. So these are not like simple ERMs. These membranes have a glial tissue as well. So, and they may have a subretinal component. So there can be a perforation at one site where they are connecting with the subretinal space. So we may not be able to peel them completely all around, but at least over the macula and towards that node of where the subretinal tissue is, we would have to trim it and leave it behind. So that is the posterior hyaloid being lifted off using the triamcinolone, like Dr. Tarun Sharma mentioned in this last talk. And subsequently you can see the epiretinal membrane out here with a little bit of glial tissue, and you can see there is this scar, choroidal atrophic scar. So we peeled it and trimmed it and left it there. We cannot remove that residue. If we try to remove this residue, it's going to create a retinal break and a large subretinal hemorrhage. So the mechanics of the trauma, when there's a blunt injury, there are the 7 rings in the eye which can get affected. So you can have hydrodialysis, cyclodialysis. Like that, we can have posterior to the muscle ring, can have the vitreous base avulsion. And if the trauma is very bad and the vitreous base attached strongly, you can have a peripheral retinal dialysis or a peripheral retinal tear. So what we see here is the vitreous base avulsion. So this will appear like a bucket handle. This is the vitreous base avulsion. You can see this is not a detachment or a tear. So this is the vitreous base which is avulsed, and like a U, it will be falling in front. So underneath that, we need to make sure that there are no retinal breaks at the ora. So no dialysis. If they are, then we are going to treat them with laser photocoagulation. Most of these patients do not have a detachment when they present with us. Other things are retinal detachment. You can very rarely have a lens under the retina or choroidal detachment. We went through that earlier. And as I mentioned, the trauma is a little bit more. In addition to vitreous base, it can tear off the peripheral retina, most often coming back with like a giant retinal tear. So giant retinal tear surgery in trauma is nothing specifically different. We go ahead with the giant retinal tear surgery just like how we would for any other giant retinal tear. That's the anterior flap of the retina being removed, the perfluorocarbon liquid, then we attach it and do laser photocoagulation. So you can see the perfluorocarbon liquid, and that's the giant retinal tear, what you see there, out here. PVR in trauma, it's been dealt with earlier. And subretinal hemorrhage is something which can be commonly associated in traumatic eyes. So this is once again a perfluorocarbon liquid in an attempt to displace a submacular hemorrhage. If the hemorrhage is away from the macula, then we can leave it alone. We will see a plume of the subretinal hemorrhage coming out here. You can see this yellow-brown liquid coming out here. That's the altered subretinal hemorrhage coming out through a break in that area. So we're trying to displace the subretinal hemorrhage and leave the macula without the subretinal hemorrhage in these situations. And we don't operate in all the patients. Usually if there is a very thick submacular hemorrhage, then it's better to attempt surgery, and many of the times it's clotted and may not come out, so better to use a TPA, like inject it under the subretinal space, wait for about half an hour to 45 minutes and then remove it. An IOL can also dislocate inside following a blunt injury. So retinal detachment is a common reason why we do vitrectomy for a closed globe injury. And fortunately, more than about 3/4 of the patients get back more than 20/400 vision. And what are the risk factors of poor vision? Delayed presentation, macula off detachment, presenting vision is less than 2400, and repeat surgeries. So this were some of the slides we did look at them earlier. So if we find a large clump of clot right over the disc and we can see the retinal whitening out here, then we need to suspect the patient may have very poor vision like NLP. We need to suspect optic nerve avulsion. So the same patient, the hemorrhage resolved to some extent, and this is the last picture. So you can see the large scar, the optic nerve is kind of dipping inside, so there's an optic nerve avulsion. You find a large clot right over the disc with a very poor vision, we need to suspect this with the retinal whitening. Other things can be an optic atrophy without any reason. Brow trauma can transmit the trauma to the optic nerve. The patient can just present with an optic atrophy. Sometimes they can have a retinal break like this. This is almost necrosis of the retina and left